Welcome back to Psychedelic Therapy Frontiers, the podcast devoted to exploring the frontiers of psychedelic medicine and what it takes to cultivate a healthy mind, body, and spirit. I'm Dr. Steve Thayer, and today my co-host, Dr. Reed Robinson, and I are joined by Dr. Eric Garland. Dr. Garland is the Distinguished Endowed Chair in Research, Distinguished Professor, and Associate Dean for Research in the University of Utah College of Social Work. He's the director of the Center on Mindfulness and Integrative Health Intervention Development, or C-Mind, the associate director of integrative medicine in supportive oncology and survivorship at the Huntsman Cancer Institute, and research health scientist in whole health at the Salt Lake City Veterans Administration Medical Center. As you can see, Dr. Garland does a lot of stuff. In fact, Eric is the most prolific author of mindfulness research in the world. We had him on the podcast today to talk about the mindfulness-based therapy intervention he created and studied thoroughly called Mindfulness-Oriented Recovery Enhancement, or MORE. Great acronym, by the way, and Eric is a master at naming things. We discussed Dr. Garland's research on MORE's effectiveness, particularly with substance use disorders. We also talk about the ongoing and upcoming research combining MORE with psychedelic medicines. In fact, we're honored to be working with Eric on a phase 1 clinical trial of ketamine-assisted psychotherapy and more for opioid use disorder. We're honored to have him on the podcast today. Please enjoy our conversation with Dr. Eric Garland. All right, welcome back to Psychedelic Therapy Frontiers. So for those of you who were watching on YouTube, we've only done this, I think, one, maybe two other times, Reed, where we've done it remotely.
Yep.
And use this platform. So here we are. We have a special guest today, Dr. Eric Garland. So I will have introduced Eric in our pre-roll intro. But Eric, would you mind just giving us a brief introduction into who you are and what you do?
Sure. So I'm Distinguished Professor and Distinguished Endowed Chair at the University of Utah and the Director of our Center on Mindfulness and Integrative Health Intervention Development. And I'm both what I like to call a biobehavioral clinical researcher, as well as a psychotherapist. And I've been working in the area of mindfulness and addiction and chronic pain for about the past 15 years or so.
You said biobehavioral clinical research?
That's right.
I've never heard that term.
I do NIH-funded clinical trials of the mindfulness-based intervention that I developed, mindfulness-oriented recovery enhancement. But all of these federally funded trials, whether it's NIH or the Department of Defense, for example, I typically also do psychophysiology or neuroscientific measures along with the clinical trial to understand not only does the therapy work, but also how does it work? What are the mechanisms by which it works? How does mindfulness change the brain and the body to produce clinical benefits?
Right.
So hence biobehavioral clinical researcher.
Love it.
Yeah,
I love that because you're looking at you're looking at neurological, biological mechanisms, but also behavioral and psychological mechanisms, and maybe where the two are connected, where they correlate.
Exactly.
Yeah, it's been a missing link in having been a clinical researcher in the neuropsychiatry space for a long time. That's been a big missing link, is that part of the puzzle, how things work, because we have a lot of challenges in the neurosciences, with the placebo response and with some of these therapies we don't understand, or with the brain that we definitely don't fully understand. But I love that you're able to weave those things together in the trials you're doing.
Yeah, it's always seemed really important to me because, my philosophy around this, actually as a clinician, is if you don't know what makes the problem tick, then how are you going to address the problem? And so starting from that as the basis, starting with a mechanistic kind of conceptual framework as the basis, then we can build interventions that can address the processes that have gone awry in our patients. Yeah. And so I built my mindfulness-oriented recovery enhancement intervention on that kind of a mechanistic conceptual framework. And I've been optimizing it over the past decade based on what we've learned from the mechanistic studies about how the therapy is working I've used that to kind of feed back into the treatment development process to make more a better treatment.
Maybe you could break it down for us, taking addiction, for example, or whatever condition you'd like to start with, of what makes it tick and like what is more and how does it get in there to the mechanism?
Yeah, I'm happy to do that. So from sort of the basic science perspective, the basic behavioral science perspective, looking at addiction, one of the processes really there are two kind of mechanistic pathways that have interested me quite a bit. The first is the notion that addiction arises out of automaticity. So it's an automatic habit that develops like any other automatic habit. When you do a behavior and the behavior is reinforced, that behavior tends to reoccur. And as these cycles of behavior and reinforcement occur over time, it embeds that behavior as an automatic habit, something that occurs outside of consciousness. We see that, for example, with a cigarette smoker. You light a cigarette, and a lot of people don't even realize they have a cigarette burning in the ashtray while there's one hanging out of their mouth. Or you hear people in recovery say, I know this drug is killing me. I really want to change my life. I don't want to do this anymore. And then they do it anyway. And it's not that they're actually lying. They're being genuine, that they really do want to change. But there's another part of the mind in which the behavior has become so automatized that it occurs outside of conscious awareness and outside of the person's self-control. So that's one mechanistic process that's relevant to the development of mindfulness-oriented recovery enhancement. The other is what happens to the reward system during the process of addiction. And that is, as a person becomes more and more addicted, there are changes that occur in the reward system of the brain and the extended amygdala, such that the brain becomes hypersensitive to stress, pain, and drug-related cues, and it becomes insensitive to the reward obtained from natural, healthy objects and events in the social environment. So the things that used to make the person feel good, they start to lose their luster as the brain's reward system becomes hijacked by the drug. The brain becomes hypersensitized to cues related to the drug and drug taking, and it becomes insensitive to natural, healthy pleasure. And so this leaves the person in a hole. They feel dysphoric. They feel empty inside, and they start to scramble to take higher and higher doses of the drug just to feel okay. But then that further drives this downward spiral of loss of control over drug use. So, given these, and I guess actually there's a third process, and that this will enable me to reference the third component and more, which is as this process of dysregulation occurs in the brain, the prefrontal cortex also becomes dysregulated, and its ability to tamp down stress reactions through emotion regulation. So the person they become more sensitive to stress. They become less able to use conscious self-regulation of their negative emotions. And actually, we have some new data that just got published in Biological Psychiatry showing that when people who misuse opioids try to actually regulate their negative emotions, it often backfires and makes their brain even more hyperactive to negative emotional stimuli. So it's a trifecta of misery. This automatic habit of addiction takes hold. The person is unable to regulate their negative emotions effectively, and they can't make themselves feel good naturally. They can't experience natural, healthy reward. And that combination of deleterious factors gets them pretty stuck in addiction. So,
Eric, sorry to interrupt, but I just want to highlight, underscore that stuckness that you're describing and the way that you're describing it. To me, it evokes a lot of compassion for the human that has the addicted brain, because a lot of it's not hard to judge people who are addicted. At least it hasn't been for a lot of modern history. These are moral failings. This is a lack of willpower. Throw them in jail. They're dangerous people. They're weak or whatever. These are some of the really negative attitudes a lot of people have about those who are very addicted. And what I'm hearing you say is that the brain is literally changed, is literally different. They experience discomfort and stress differently than the human with the average brain. Am I hearing you right?
Definitely. And it's a trap that people fall into, and they don't realize it's going to happen from the start. It's a very insidious process, because a lot all of this, we didn't even start with what leads people to become addicted in the first place. Why do they make the choices to
Right.
use and overuse drugs to begin with? And in a lot of cases, people are seeking relief from emotional pain, because whether they've had a lifetime history of trauma or they have some sort of untreated mental health conditions, they're taking the drug to make themselves feel better, and it works temporarily. It temporarily alleviates the distress, but then becomes very reinforcing, and it gets them hooked in this cycle where all of a sudden the original distress that drove the addictive behavior becomes magnified, and they don't even realize it. They just start feeling worse and worse, and that makes them more and more dependent on the drug just to feel okay, and it's just the vicious cycle.
Right.
So I do have a lot of compassion for people with addiction, and I really don't judge them, because I think that addiction is just a manifestation of normal human learning processes gone awry, gone bad, and it could really happen to anybody.
Yeah, absolutely. Could happen to anybody. And before I interrupted you, I think you were going to segue into the treatment, into more.
Yeah. So given this understanding of what's going on in the brain that is propelling addiction, so we need treatments that can directly address this deficit. And so I developed mindfulness-oriented recovery enhancement, or MORE is the acronym, to directly target these mechanisms by integrating three kind of great traditions within psychotherapy. So MORE integrates mindfulness training, third wave cognitive behavioral therapy, and principles from positive psychology into a coherent treatment approach. So we use mindfulness. Mindfulness is really well suited to address this automaticity component that I was speaking about. Because mindfulness is all about becoming aware of our own automatic reactions, and then gaining self-control over those reactions. So it really is it's a form of training the mind to become aware of our habitual patterns of thinking and acting. And then once we have that self-awareness, we can self-regulate the behavior and the cognition to live a better life. So build that's sort of the basis, that's sort of the platform of MORE, that's the foundation. And then on that we scaffold these other therapeutic techniques. So we add reappraisal techniques from cognitive therapy to teach people how to regulate their negative emotions by reframing the stressors or the adversity in their life as an opportunity for personal growth, or to find a sense of meaning. And then building upon that then is the third layer of technique, which is the technique of savoring. And savoring is really critically important. I think it's one of the things that makes MORE really unique, and one of the things that makes it most effective. So savoring is the process of focusing mindful attention on what is pleasant, beautiful, and good in life. So focusing your attention on pleasant, everyday experiences, and really trying to just extract all the goodness that you can from that experience by focusing on the beautiful sensory qualities of that object or that experience. And then even more importantly, when you're savoring something good in life, whether it's the beauty of a sunset, or the sound of a bird singing in the tree, or seeing flowers, pushing up from your neighbor's garden when you're walking down the street, not only savoring the beauty of those those objects, the sensory beauty, but also becoming aware of when positive emotions start to arise in your mind, and becoming aware of sensations of pleasure arising in the body. And then savoring involves this sort of reflective process where you turn your attention inward and you focus mindfulness on the pleasant inner feeling in the mind and body, and you savor the pleasant inner state. And doing that really deepens and expands the savoring experience, and ultimately, can lead to this sense of not only feeling good, but even intense sensations, even in sensations of bliss, which are really important in the treatment of addiction, since we talked about the fact that as the person becomes more and more addicted, they're less able to experience a sense of natural, healthy pleasure out of life. So this savoring technique is really designed to address that.
So it rebuilds their bliss radar. Is that where positive psychology and mindfulness kind of meet in more? Because I'm thinking of, for a lot of people, what's salient, and this is kind of not even for a lot of people, this is typical of the human mind, are the negative things, right? We're generally a little bit more sensitive to negativity, and maybe that's an evolutionary advantage, right? We paid attention to things that could be a threat to us. But in today's day and age, it can result in a lot of chronic stress or distorted thinking, negativity bias, catastrophization, things like that. So it takes a deliberate practice, like this savoring practice, to draw our attention to and actually feel, not just skim the top of, but actually feel to our core the beauty of what we're experiencing, the pleasure or the bliss of what we're experiencing. And that by doing that more often, Eric, it's engaging that learning process you cited at the beginning, to where we become then maybe even more sensitive to the natural sources of bliss, and we resensitize our little bliss feelers inside.
That's right. And so we've published now many times over, using various physiological measures, showing that being treated with the MORE program actually increases the brain and the body's responsiveness to natural, healthy reward. So we bring people into the lab and we show them images of smiling babies, lovers holding hands, beautiful sunsets, and we measure how reactive their brains are to these stimuli using EEG, and we measure how reactive their bodies are using autonomic nervous system measures like heart rate variability. And we've shown in multiple studies that MORE increases the brain's and body's responsiveness to natural, healthy reward. But what's even more amazing is the increases in physiological responsiveness to natural, healthy reward are correlated with decreases in craving and addictive behavior. So in fact, the effect of MORE on reducing future opioid misuse behavior is statistically mediated by increases in the bliss feelers, as you said. Yeah, go ahead, Reed.
Oh no, go ahead, finish your thought. Then I have a question on one of those.
Yeah, so that's really the most, I think that's one of my most important scientific contributions. These data have been published in a number of really high impact journals, including Science Advances, that was published 3 years ago. And I have this hypothesis, and I call it my restructuring reward hypothesis, which states that if you can help somebody shift from valuing drug-related rewards back to valuing natural rewards, then that will reduce craving and addictive behavior. And that hypothesis has been supported now by multiple of our studies. That's exactly what we find, that the extent to which we can use MORE to help people to become more sensitive to natural, healthy pleasure, the less they crave the drug and the less they use drugs.
Probably infinite follow-up questions on that, but one I just wanted to get underneath the hood of a little bit is not going into the black box of EEG brain waves, but on the autonomic nervous system front and HRV, what do you look for, or how is that useful in measuring someone's reward response?
It's really, heart rate variability is a pretty general biomarker. We're looking at high frequency heart rate variability. We're looking at really parasympathetic nervous system response. And so showing increases in parasympathetic nervous system response during uh, savoring of natural reward. Um,
So you're seeing
in,
the HRV in the moment while looking at these normally blissful or positive, good feeling things. You see HRV go up if you're measuring
right.
like the moment to moment HRV as a measure of your parasympathetic kind of predominant or front and center, and your fight or flight is toned down more than it might have been before.
Yeah.
And then what does it look like to help someone move from, move back to feeling bliss? Like, how do you, like, you
What does it
work
look
on
like?
savoring, like focusing on savoring experiences, like
Yeah. Are
meditating
you
on
going to describe the technique?
yeah, or whatever ways you use, or an example perhaps.
Yeah. So we teach that. We don't teach that skill until the fourth session of more. So there's been in the first several sessions, we're teaching pure mindfulness meditation training. And that's really by design because the thought is we need to help the patient to develop some attentional stability, some clarity of mind, and some ability to access meta awareness before we introduce the skill of savoring. But then we introduced the skill. We used when we were doing groups in person before COVID hit, we would bring in a bouquet of roses, and we would have each patient take out a rose. They'd get to pick the rose they liked, and then they'd focus their mindful attention on the rose and appreciating the pleasant colors, the textures, the scent of the flower, the touch of its petals against their skin. And then during this process, the therapist guides the patient to turn their attention inward and to notice the arising of any positive emotions or pleasurable body sensations during savoring. So, when you do this, maybe you notice sensation of tingling in your fingertips as you touch the rose. Maybe you're noticing a feeling of warmth spreading through your chest as you're smelling this flower. And when you notice these pleasant sensations, really focusing mindfulness inwardly and focusing on to appreciate the pleasant sensations, and then we guide the patient to absorb those positive feelings like water seeping into the soil is the instruction we use. Absorb them into the center of your being, as if you could sort of breathe in those positive feelings and let them expand. So then, nobody can stay feeling good for forever. So as those positive feelings start to fade away, we then guide the patient to open up their eyes and to refocus on the rose to sort of refresh the savoring experience. So get back in touch with the pleasant sensory qualities. And then when you notice the positive feelings arising in the mind and body again, turn your attention inward again to savor the positive inner feeling. And so the person kind of oscillates back and forth. But one of the interesting things that happens sometimes was as a person is savoring, and this could be a bridge to talking about um, psychedelics, is doing this practice. A lot of times people have the experience of feeling this sense of closeness or connectedness with the object that they're holding, almost a sense, when savoring gets deep enough, almost a sense of oneness between the self and the object that you're savoring. And that seems to be an important part of the experience.
Yeah, it makes sense to me. And it makes me wonder if, so you've tested more mostly in the treatment of addiction, opiate use disorder in particular. Has it been tested with, treatment-resistant depression? Because when I think of what maintains depression, especially melancholic, low mood, but sort of the apathy, what's the word I'm looking for?
Anhedonia.
Anhedonia is the word I'm looking
Yeah.
for. Yeah. Because you're basically teaching them how to feel pleasure again through this exteroceptive, interoception sort of back and forth, where they can not only perceive the external stimuli that might be pleasant, but they're paying attention to their internal reaction, and they can carry that with them from moment to moment, which is really hard for somebody with sort of melancholic depression.
Yeah, that's right. So let me talk briefly about the outcome data, and that will connect to your question. So I've been doing clinical trials of more for the past 10 years. But we just recently finished the largest clinical trial of more to date. This was published a couple weeks ago in the top medical journal, JAMA Internal Medicine. And this was an NIH-funded randomized controlled trial. It was a 5-year trial, a multi-million-dollar study. At the beginning of the study, we enrolled 250 people with chronic pain who were misusing opioids at baseline. And we randomized them to receive 8 weeks of more or 8 weeks of a standard supportive group psychotherapy control condition. And these folks, in addition to having chronic physical pain, and they were taking high doses of opioids at baseline, there was also a lot of psychiatric comorbidity. So almost 70% of the patients met criteria for major depressive disorder, to your point there. And then there were also high rates of generalized anxiety disorder and PTSD as well in this sample. And so, in summary of the findings, this trial was a total blockbuster. So more reduced opioid misuse by 45%, 9 months after the end of the 8-week treatment was over. And that was more than double the effect of standard supportive psychotherapy. And at the same time, more reduced physical pain. So about 50% of patients achieved a clinically significant reduction in chronic pain intensity. And then lastly, as I spoke about a moment ago, about 70% of patients met criteria for depression at the beginning of the trial. But 9 months after the end of the treatment, patients and more were reporting depression symptom levels beneath the cutoff for major depressive disorder. So more had a really powerful antidepressant effect as well. And I think you're spot on. I mean, I think that helps to explain why we're training this exteroceptive attention, interoceptive awareness, kind of toggling back and forth, the savoring, which should be really therapeutic for the treatment of depression and anhedonia specifically. And actually, we published a paper last year showing that more significantly decreases anhedonia, and that increases in brain responses during savoring actually mediate the effect of more on reducing anhedonia. So more is increasing the brain's sensitivity to natural healthy pleasure, and that helps the person to actually re-experience pleasure in life.
Right.
Which is pretty important because as we talked about at the beginning of this interview, that's one of the things that's driving addictive behavior, the dysregulation of the brain's reward system, the inability to feel good naturally is pushing people to get stuck.
Right. Well, and incidentally, it's that ability to feel good naturally, to derive pleasure from day-to-day activities, also for a lot of people is reduced when they're on standard SSRIs, right? Antidepressants will sometimes blunt the top edges of pleasure for people. And you just don't see data like that for a lot of psychotherapy studies. Like a lot of psychotherapy outcome studies, you don't get 45% reductions, and you don't get people, reducing below baseline with durability too. 9 months out, that's pretty impressive.
Yeah, it is. And one other point that I just kind of free associated with what you just said is, when a lot of people have heard about the savoring approach, they say, oh, well, yeah, that's like behavioral activation in CBT. We're giving people pleasant experiences, and that's not the case actually,
No.
because your body can be doing something pleasant, but your mind can be lost in a world of suffering. So what we're doing in more is as you said, we're training people to become aware of when their mind is getting stuck in that negativity bias, and then to zoom out from that, expand the field of awareness to start to notice the parts of their life that are actually not bad and maybe even good, and then really tune attention into those moments to suck every drop of goodness that you can out of life. And that seems to make a big difference.
And before we launch into that psychedelic segue, because that'll be interesting, what's happening, do you think, to the neurotransmitters when this is going on?
Well, I have lots of hypotheses. I don't have any data at the neurotransmitter level, but there are actually some colleagues of mine in Switzerland are now doing a study using F-DOPA PET to measure dopamine release in the brains of people with fibromyalgia who are being treated with more. So in a couple of years, we'll know whether more is increasing dopamine release. I think another candidate neurotransmitter mediator is endogenous opioids. My suspicion is that more is increasing endogenous opioid release during the experience of internal pleasure. And I think there's probably also an endocannabinoid mediator as well. Those are just some guesses, though. We really don't know.
Makes me wonder about receptor site too. Like, and I don't know. I'm not familiar enough with neuroscience to know how one might measure this. The two of you could school me on that. But like dopamine, receptor downregulation, I think, is a problem. And I wonder if a process like this helps upregulate those receptor sites.
Yeah.
Who knows, right?
Good hypothesis. I don't know.
I think people talk a lot about dopamine and that issue these days, and I think you were featured in an article in Time recently with Anna Lemke, right? Who's
right.
The one in large part responsible for a lot of the discussion these days on dopamine, at least on the podcast circuit and in some of the recent research. So yeah, that's fascinating. And then I could just picture the future headlines if some of those neurotransmitter studies find that like anandamide is
right.
like upregulated. The first endocannabinoid discovered that is named based on the word for bliss in Sanskrit, right? Ananda.
Exactly. That's that's my armchair neuroscience. I think we might see an effect in the anandamide receptors because by its namesake, bliss, and that's really this is a really far out kind of approach. I don't think anybody's really thought about up until this point the notion that we could teach people how to self-generate natural, healthy bliss, joy, and pleasure, and to the extent to which that bliss could actually essentially be a natural high, if you will, that then would provide an alternative to getting high through a drug.
Right.
That makes sense.
So it's a pretty simple explanation, actually, but I think it has merit.
To me, it sounds like a perfect protocol for what we often talk about on this podcast, and that is integration of a psychedelic experience. Because you made reference to this feeling of oneness with the rose, right? In the exercise that you use with your clients, which is a feeling that people often have when in a psychedelic experience, whether it's ketamine or psilocybin or LSD. This feeling of joining with the universe, joining with the world, joining with their loved ones, that we are all one. The mind body split is no longer experienced, and that often will generate internal empathy and empathy for others. It'll generate internal compassion and compassion for others. And we talk a lot about in our work with ketamine that the experience itself can provide for somebody a corrective emotional experience, but it usually doesn't correct permanently, right? We need to build on that corrective emotional experience. I like to talk about dropping breadcrumbs on your way out from this bliss field that ketamine has provided for you, so that you can follow them back there during normal waking consciousness, non-ketamine consciousness. And it seems to me that what you're describing here with more would be perfect for that, because you can reference your ketamine experience as a nice anchor point. A lot of people struggle with mindfulness training because they just don't know what it feels like to be where you're trying to get them to be, especially if they've been addicted or depressed for a very, very long time.
Yeah, I mean, everything you said makes good sense to me. So we're obviously interested in the potential of synergizing more by combining it with psychedelics. And my interest in this area is actually largely data driven. And the reason why I say this is, so in 2018, my colleagues and I developed a self-report measure to measure transcendent experiences. And we used a pretty rigorous psychometric approach of exploratory and confirmatory factor analysis. We took all of the sort of existing scales of mysticism and altered states of consciousness, and we boiled all those items down into the 13 best items, the items that were the most sensitive. And so we built this instrument. We published it in a top psychological assessment journal, and then we started using it in our studies of more. And we found, to our surprise, that more was significantly increasing self-transcendence, which was operationalized in sort of three ways. One is the experience of annihilational unity, so the sense of oneself dissolving. The second is more of a dimension of relational unity, so the sense of being connected with everything, unified, a sense of oneness with the universe. And then the third dimension was the blissful affective tone that attends these experiences. So the sense of universal love, or a deep sense of bliss, or a sense of energy in the body. And we found that more was significantly increasing self-reports of these experiences. But what was so amazing to us was that the effect of more on improving clinical symptoms was statistically associated with increases in these self-transcendent experiences.
Mm-hmm.
And to my knowledge, so we published those data in the Journal of Consulting and Clinical Psychology, which is a very straight-laced, very rigorous and well-regarded clinical psychology journal, a couple of years ago. And when I saw that, and which I think is really the first demonstration in the scientific literature that increasing self-transcendent experiences through meditation could have clinical benefits, I thought, wow, this is a really important mechanism. And
Mm-hmm.
so maybe there are other ways to enhance this mechanism that could even result in even better clinical outcomes. And so psychedelics is clearly a way to do that, to induce self-transcendent experiences. So we've been interested in combining the two. And in our current approach, in our current study, where we're a clinical trial where we're combining more with ketamine-assisted psychotherapy, it's kind of both ends. So we're preparing the patient in the beginning with more and mindfulness training before the psychedelic experience, to sort of give them the tools to maximize that experience. But then we're also, after the psychedelic experience, they're going back to the more therapy for that integration purpose that you just brought up.
That makes a lot of sense, because it seems like it would be a useful skill. The skills that you're teaching would be useful in navigating the psychedelic experience. Sometimes, we talk about the difference between quote unquote good or bad trips, or challenging or useful trips. And sometimes what makes a trip challenging, ketamine experience in this case, challenging to the extent that it's actually not very therapeutic, is a person's resistance to the experience. And so we often use mindfulness as a tool to help people become more skilled at being where they are, who they are, and how they feel without resisting, so that they can sort of sail through the experience and make it productive, even if it is challenging. So it makes a lot of sense that you could use more to prep and to integrate, and that the skills you teach might be useful during the experience itself.
Yeah, and then in terms of the breadcrumb piece, which I like that term, we're doing something which I also think is really important, which is as the person is emerging from their ketamine experience, so about an hour or so after they've received the dose, we're teaching them how to meditate again. So we're giving them the same instructions that we've given them for 5 weeks before they had the psychedelic experience. But now we're giving those same instructions again as they're sort of emerging from the state. And the hope is, my thought process is that maybe as you said, the bliss field that is generated from this state will be some sort of a stamp in memory,
Mm-hmm.
that will be further etched in as the person is practicing mindfulness. And then that will become a reference point. So then in the future, when they practice mindfulness, they'll be able to kind of re-access that state, at least some of the qualities of that state, which will help deepen their practice. So who
Yeah.
knows if it'll work? We'll see.
Oh, I think it's that's very, very wise, a smart approach, because there is data on ketamine and S-ketamine, just like there is on other like classic psychedelics, showing that there's a window of opportunity opened up of neuroplasticity, or a critical period of enhanced learning. And so I'd be really interested to see what happens to that meditation training then. Is there a way you can measure it? I guess you're just looking at the ketamine group versus, is it a ketamine group versus a control group with ketamine and no more, or with ketamine with no ketamine?
The control is more without ketamine.
Okay.
That'll be really interesting because you've got established data to show that more is helpful. So does ketamine add anything appreciable to what more already provides? Yeah,
exactly. But that neuroplasticity notion, that's sort of it's a second level of this process. The first is on the phenomenological level. Does having this experience, this conscious experience of this heightened transcendent state become a marker that the person can then kind of refer back to and and tap into. So that's more at the psychological level, and then at the neurobiological level, can we take advantage of the neuroplasticity that's being stimulated from the ketamine experience to produce new neural connections and strengthen neural connections that'll facilitate learning. So it might do both of those things. It might do neither of those things. We really don't know, but it's going to be a pretty exciting study.
Yeah, no, that's awesome. You know what? It strikes me that some drugs of abuse, like cocaine, induce this hyperplasticity, like hyperplasticity being a bad thing, where it's harder to learn or lay down new neuronal connections and tracks.
Yeah, you don't want your mind so open that your brains fall out. That's what an old coach used to tell me. But I wonder if the trajectory of improvement changes between those two groups. Like you might get the same total improvement between the two groups, but maybe the ketamine group achieves, remission faster than the non-ketamine group.
Yeah.
Sometimes, because we call it ketamine-assisted psychotherapy, I've heard people refer to it as ketamine-accelerated psychotherapy. We think that for some folks, it's not that they get even better with psychedelics, although that could be the case, but they just get better faster, and it's more durable.
Yeah, any of those would be fantastic outcomes, and it'll be really interesting to see how the intensity of the self-transcendent state that is achieved, how that maps onto the clinical outcome, because certainly the transcendent experiences that are being induced by the ketamine in this study are very powerful. People are scoring at the high end of the range on the non-dual awareness dimensional assessment that we developed.
Is that what it's called, Eric? What's the instrument called?
It's called the NADA, which I think is pretty funny.
I was going to say, you are really good at naming stuff, man. Like, more is awesome. I was telling our producer, like, it's not one of those tortured metaphors where they had to, like, pull letters from the middle of words to make something sound good. And even those...
We lucked out with that, but NADA's pretty funny, right? Who's home? Nobody's home. NADA.
Yeah. What's it stand for?
Non-dual awareness dimensional assessment.
That is so good. And I love the three dimensions I think that you said you measure. Can you go over those again? Because those are well named. There's you said annihilation.
Yes, there's annihilational unity.
Yeah.
So that's when the sense of self disappears. Then there's relational unity, and that's the sense of interconnectedness or oneness between the subject and the object, which is really the non-dual awareness, right? Is the opposite of dual awareness. Dual awareness is subject viewing object. So in relational unity, the subject-object distinction collapses as the person becomes connected with the world around them. And then the third dimension is the affective bliss
Mm.
So the emotional bliss and the sense of love, compassion that arises.
I love that you developed this questionnaire and that you did it, in a psychometrically rigorous way, because a lot of people ask us, what is it about a psychedelic experience that would be helpful? Like, all I know is what I know from the War on Drugs campaign in the 60s and people flipping out. Why would ketamine or why would MDMA or LSD or psilocybin actually be helpful? And I might try to explain this non-dual state, becoming one with everything, and still to the uninitiated, it's like, well, okay, but that sounds unpleasant. Like, I don't want myself annihilated. Why would
Right.
that be helpful? So being able to have a theory that backs it up and then correlate it in this study with improvement is, I mean, you're bringing the science to the esoteric. It's pretty awesome.
Thanks. Yeah, we're really excited about it. I wouldn't have done this early in my career because it's too far out there, quite
Yeah.
frankly. But now I'm a distinguished professor, so I don't think they can take that away from me.
It's good timing, though. It's good timing because you have this, very respected and scientifically rigorous career. You've developed this thing in more that is helping people anyway. But like we've been talking about today, it's so well positioned, I think, to be paired with psychedelics. And here we are in the bowels of the psychedelic renaissance, doing really, really good research. And I would argue even better than the research that was done back in the 50s and 60s. Better by meaning better designed. The studies are better designed. It's got more buy-in, hopefully, from the larger community. We do have to kind of climb out of what happened back at the end of the 60s, but I think we're basically at the rim of that pit. So it's really cool to be able to combine stuff like you've created with what we think is going on with psychedelics.
Yeah, and I agree. I agree about the rigor, and it's really, really important. And just my 2 cents on this. I think that there's a lot of hype going on right now in the psychedelic world,
Mm-hmm.
definitely clinically, and definitely in terms of research. Um, and I think that's dangerous for the field. I also think there's some really high quality research being done. Incredibly well crafted, rigorous research that not only has uh, important implications for understanding the therapeutic value and the neurobiological mechanisms of psychedelics, but I also think it can really shed light on some of the big questions in neuroscience and psychology, like what is the nature of consciousness. So
Right.
I think there's a lot of promise there, but I think we got to be really careful about not hyping anything up. And the best trials that have been done are are small and not well powered, with the exception of the MAPS PTSD trial, which was fantastic, and that one is a clear winner.
Right.
But some of the psilocybin stuff is still largely not ready for prime time yet, and but it's been hyped, I think, as if it has shown
Mm-hmm. Mm-hmm.
definitive efficacy where it really hasn't. Um, but I think as long as we go about this in a really rigorous way with a lot of transparency and with proper controls put in place and considerations of safety and all of that, then I think there's a ton of promise. And I mean, what this year was a major turning point, right? Because NIH funded its first psychedelic study in what, 50 years? I don't know.
Yeah,
So
it's Matt Johnson's study, right?
yeah, so that's just huge, and I think I know Dr. Volkov, the director of NIDA. I've had the great fortune of working with her as a member of the NIH HEAL multidisciplinary working group, and she's one of the most brilliant minds in the world and in the history of science, I would say, and she's a very conscientious, very ethical, very rigorous person, and so NIDA she had to sign off on that. So NIDA would have never funded that research if they thought that the rigor wasn't there. So that I think is a really positive statement on the promise of the field.
Yeah, Eric, spoken like a true clinical scientist, I appreciate the caution against the hype. Hype is something that happens when promises outpace the data, and you are drawing our attention back to the data so that we can, if we're going to make promises clinically, or at least express hope clinically, that it's based on good, rigorous data. And you do tend to see that when people get excited, and there's reasons to be, let's say, cautiously optimistic, but optimistic about this. And I appreciate sort of the inside baseball about NIDA. That's encouraging.
Yeah, definitely. And I would also, as I'm calling things out here, I also say that there have been a number of really high quality and ketamine studies as well that were just published in the American Journal of Psychiatry in the past couple of years, looking at ketamine assisted psychotherapy as a treatment for addiction. So yeah, I think there's a lot of promise here, but we can't get ahead. We can't get ahead of the science in making claims of efficacy. It takes a long time to prove it. I mean, I've been in the middle of that process with the mindfulness-oriented recovery enhancement intervention. It's taken me over 10 years to be able to put my foot down and say, now we know this thing works. So with appropriate caution and rigor, I think this could really go far.
What's next for you, or what's on your wish list for more as far as psychedelics go after ketamine?
Good question. Well, I think it'd be really interesting to study the potential of combining more with psilocybin or MDMA. I think both of those are really promising potential approaches, and I would personally be interested in looking at this combination for the treatment of opioid use disorder, given that we know that more really is quite efficacious for treating opioid misuse. Can we expand Moore's reach and accelerate the healing process with these psychedelic agents? And then with respect to the MDMA, we know there's a lot of comorbidity with PTSD and opioid addiction and chronic pain. And so would combining more with MDMA help to address this comorbidity? I think it probably would. Those are my thoughts. I mean, I've also, I've heard about ibogaine as a potential treatment for opioid addiction. I don't think we know enough about that yet, period, to think about combining with more necessarily. But I think generally speaking, the notion that we could use a psychedelic agent to accelerate therapeutic neuroplasticity in people suffering from substance use disorders and their comorbidities, including chronic pain and psychiatric disorders, that there's an obvious place for combining that with a comprehensive psychological intervention like more that could be useful for preparation as well as for integration.
So much promise, Eric. I'm mindful of your time and want to be respectful of your time. I really appreciate your willingness to shave off this hour for us. I want to say about more. It's when I first discovered it, I would just I experienced a lot of joy and bliss because it was this combination of the three forms of psychotherapy or schools of thought that I fell in love with in graduate school. And I remember being, as a clinical psychologist, we had to write what was called our theory of change essay or paper, where we, and we barely know what we're talking about at that point in our training, but we do our best to find something that fits with us. And I remember discovering mindfulness, some third wave CBT was ACT, acceptance and commitment therapy, and then the positive psychology stuff, and just being really drawn to those things. So I don't think it's a mishmash. It makes so much sense that you bring those three things together from a theoretical perspective, but also a data-based perspective on what the research suggests about what's effective. So just sort of fanboying here. I love your stuff, Eric. I really appreciate you being willing to talk to us. If people are interested in learning more about your work, where would you direct them to go?
Yeah, they could go to my website. It's www.drericgarland.com. So Dr. Eric Garland mindfulnessoranted.com. So they
Cool.
could go there and be a good place to get more information about more and the research that we're doing.
And you do trainings, right, on more? So for clinicians, a lot of our listeners are clinicians.
That's right, and thank you for raising that. That's really my main focus right now. My next step is really to disseminate this evidence-based treatment. So I'm very committed to training clinicians. I've trained over 500 social workers, psychologists, nurses, and physicians to date and more around the U.S. and internationally. So I do a few trainings every year. I've been doing them over Zoom, so it makes it pretty accessible for folks. And the next training is going to be this summer. So if somebody's interested, please go to the website or contact me, and love for you to join us.
That's awesome. If you go to his website, you just go to the drop-down menu on more. There's a link about training, and it's got all that info there. So thanks so much, Eric. Appreciate your work, your dedication to helping people who suffer, and your willingness to chat with us about it.
Yeah, thanks, Eric.
Thanks, Steve and Reed. Great conversation.
Thank you, dear listener, for listening. It means a lot to me. Psychedelic Therapy Frontiers is brought to you by Novamind, a mental health company that specializes in psychedelic medicine and research. You can learn more about Novamind's mission to increase access to legal, safe, and evidence-based psychedelic medicine at novamind.ca. If you like what you heard, please subscribe to the podcast on whatever platform you're using to listen or watch. Also, if you're feeling generous today, please leave us a glowing review on Apple Podcasts, Stitcher, or wherever you like to listen. If you'd like to reach out to us with questions, suggestions, scathing criticisms, etc., please email us at psychfrontiers@novamind.ca. Thanks again. The content of this podcast does not constitute medical advice or mental health treatment. Please consult a medical or mental health professional if you believe you are in need of mental health treatment.